Hello and welcome to today's training, Using Behavioral Activation Treatment to Treat Perinatal Mood Disorders with Dr. Jackie Golan, PhD. This professional webinar is the first webinar in the Women's Mental Health series supported by the Hope and Grace Foundation. I am Helen Heyman, Director of Programs at ADAA. Before we get started, I would like to go over a few items so you know how to participate in today's event. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You have joined the presentation listening using your computer's speaker system by default. If you prefer to join over the phone, just select telephone in the audio panel and the dial-in information will be displayed. We will first kindly ask you to mute yourself so that we don't hear any background noise. To mute yourself, you will need to press the gray tab just below the red arrow. Kindly also switch off your webcam. The webcam tab is just below the mute tab. You will have the opportunity to submit text questions to today's presenter by typing your questions into the chat panel of the control panel. You may send in your questions at any time. We will collect these and address them during the Q&A session at the end of today's presentation. You will also be able to access materials. If you are registered and paid for continuing education credit, you will first need to provide the 4-letter CE code on the webinar evaluation form. The link to the evaluation form in SurveyMonkey will be sent to you 48 hours after the end of the professional webinar. You can either answer the assessment questions at the end of this webinar by staying online or once you got the link to the recording. If you do this online, at the end of the talk, a screen will come up with the questions. You will have 10 minutes to answer the questions. Once you answered them, please click Submit. I would now like to introduce our expert. Dr. Jackie Golan, PhD, is an associate professor in the departments of psychiatry and behavioral sciences and obstetrics and gynecology at Northwestern University's Feinberg School of Medicine in Chicago. Dr. Golan earned her PhD in clinical psychology at the University of Washington in Seattle in 1999. Her clinical internship at Brown University Medical School in Providence, Rhode Island in 2000, and her postdoctoral training at Massachusetts General Hospital in Boston, MA in 2001. Between 2001 and 2006, she worked as a faculty member in the Department of Psychiatry at the University of Chicago. And then in 2006, Dr. Golan transferred to Northwestern. Dr. Golan is a clinical researcher and a licensed clinical psychologist. Her clinical expertise focuses on the delivery of evidence-based psychotherapies for depression and anxiety, with a focus on behavioral activation and cognitive behavioral therapy. Dr. Golan's clinical research also focuses on identifying mechanisms of treatment response using multiple methods such as neuroimaging, computer tasks, biological challenges, towards the goal of developing an effective treatment for depression. It is a true honor and pleasure to work with this professional. I will now pass the screen along to Dr. Golan.
Can everyone see this now? Good morning. Thank you very much for your time today. It's been a real pleasure to pull together a lecture and a way sort of really to extend what we understand about how we use behavioral activation to treat perinatal mood disorders. I have no financial interest that would bias the information I'm going to be presenting today, and I would enjoy talking about your questions, fielding some answers for you. I think we're going to hold them off to the end of our talk today, and then certainly please feel free to email me if there's more that I could offer. I'm briefly going to talk about the epidemiology and the criteria of perinatal mood disorders, and then review the clinical challenges that we often see when we're looking at pregnant or postpartum women who present with mood disorders, particularly depression. I'll briefly talk about a Northwestern OBGYN psychiatry screening protocol that we use to help discern which patients really do need treatment. And then I'll talk in more detail about the principles and techniques of behavioral activation to specifically address the unique needs of women who are presenting with pregnancy or postpartum mood disorders. I hope to outline also the mechanisms of change so you kind of understand why women are improving or not with this particular course of care, and then talk throughout the hour about ways that you can boost your adherence and your competency using BA. Let me briefly just set the stage here. We know that the prevalence of perinatal depression is between 8 to 13% of women who are showing through pregnancy in their first trimester and then again in their third month postpartum. This happens to be the highest level in that 90 days postpartum phase. And this rate is consistent. The 8 to 13% is consistent with other studies, although we think due to lack of recognition and underreporting by women who present in OBGYN clinics, it's possible that the prevalence is a bit higher. Now, depression varies in severity, ranging from baby blues to psychosis, and we begin with the least severe, which is the baby blues. And with hormonal changes occurring just after pregnancy, up to 80% of women report emotion and physical changes called the blues. We usually see minimal impairment, there's presentation of affective symptoms, and the interventions tend to focus on four main areas: environmental change, increasing support for women, educating about these symptoms, and then also working on sleep regulation if possible. Now, of the group who experience baby blues, we know that up to about 15% of women will onset with a major depressive disorder within 4 weeks of the childbirth. What's unique about this is they obviously have DSM mood disorder symptoms, but there's a tendency to also present with distorted processing, often seen with the report of being scared by thoughts that they may harm themselves or the infant, or inadvertently there may be harm to the infant by neglecting to pay attention to things. We also see extreme exhaustion as well, and often women will require some evidence-based approach, as we've listed here, that could also include yoga, couples therapy, and potentially medication if the therapy doesn't improve their status. There are a unique set of women who also present with bipolar disorder during postpartum, and in one unique study that was done by Dr. Wisner, about 1/4 of women in postpartum who were screened positive for depression actually had bipolar symptoms. So they almost missed in the OBGYN clinic. And it's of use to us to know this, because if they start a medication that could potentially activate the bipolarity, we would want to know this early on. Secondly, these are women who are facing a high rate of relapse of any mood disorder afterwards. We know causes are related. It's a multifactorial model, and I have some lists there for you. But treatments must really focus on routine regulation, some light therapy, medications, and again, CBT, BA, and MBSR may be useful. And it's most extreme, but in a rare scenario, we will have a 1 in 1,000 mom reporting or showing some psychosis. Generally, it's observable early on within several days after childbirth. This is an important, risky time because you want to move quickly with psychiatric emergency care, either hospitalization, using some medications and psychotherapy and paired together. But these individuals are at risk for committing suicide or infanticide, and so mobilizing treatment very quickly and recognizing those symptoms is useful. There is an extraordinary diagnostic challenge we face when we're trying to recognize what depressive symptoms are in conjunction with peripartum symptoms or pregnancy-related symptoms. There's an overlap in the reports of change of energy, of sleep, of appetite, self-worth, and anxiety. And a clinician who's quite experienced at discerning the difference won't have too much trouble if you're knowing what you're looking for. And you can certainly use a self-report measure or a clinical interview to identify depression or any of the mood disorders I've just talked about. But if you're experienced in understanding what pregnancy looks like as well, then you're able to discern, and moms are able to often tell you, oh, the effect of my energy, my fatigue, my disrupted sleep is really due to my pregnancy, not due to my mood. So often you're trying to carefully disentangle the source of these symptoms. It's important to do so because this is a time where, depression during pregnancy will predict a postpartum onset of depression. The risk is higher if certainly you've had a postpartum depression before. But there are adverse effects on the development of the pregnancy and in terms of outcome in infant development. So recognizing depression and seeing it early in pregnancy could certainly make the mom a healthier state in postpartum. The value of being able to find and recognize depression in the course of pregnancy was recognized by a variety of different agencies and foundations. And there's been guidelines, for example, by the American Academy of Obstetrics and Gynecology. They released some guidelines in 2015. But it's also been mandated by certain states. And in Illinois, we have the enacted Perinatal Mental Health Disorders and Prevention and Treatment Act, which came out in 2003. Rod Blagojevich was our governor at the time, and his wife was a strong proponent for this. It requires that there has to be education about perinatal mental health for pregnant women and newly delivered moms before they leave the hospital. And that's being done by a clinician, medical clinician. And in doing so, there's a reliance on using particular screening methods. And I have listed several, there's 4 there. As long as it's a validated measure, a self-report measure that is implemented twice in pregnancy and once in postpartum, there's a higher likelihood, obviously, of catching the depressive symptoms, but also then enacting some sort of triage plan depending on the severity. At Northwestern, we decided we were going to implement the patient health questionnaire, the 9-item. You see here a 10-item because the 10th item is focusing on global assessment, sort of general burden. But the first items, 1 through 9, represent the DSM-4 and 5 symptom set. So it allows you really to ask the patient to directly how they've been feeling in the last week. And here we have Mrs. Patient on August 15th, gave us an understanding about what she was experiencing. And our attention turned very carefully and quickly to the shaded area so that we could understand the severity, but also item 9, which represents the suicide item. Anything in the shaded area should be a cause for clinical attention. This also happens to be a method by which we can then communicate from OBGYN department to the psychiatry department, in that if an individual is showing a milder version of the PHQ-9, let's say anything under a score of 10, then the OBGYN could go ahead and coordinate care directly with their patient to give them a sense of resources, community support, and help the patient to self-manage. But anything higher than 10, there's probably a very high likelihood that that patient, the mom, is showing a depressive disorder, and there should be more education, ongoing monitoring, and certainly if anything 15 or higher, there should be a triage, if possible, to a psychotherapy or medication. And in our case at Northwestern, we actually have a collaborative care OB psychiatry program ensconced right on the outpatient space in the obstetrics and gynecology department. So mom who's going in for a prenatal check, who then presents with a PHQ that's quite high, could simply walk across the hall to meet with a psychiatrist or a licensed clinical social worker who's got specialty training in treating perinatal mood disorders, and certainly can provide the care right on site. So that would allow there to be a direct partnership between both departments for the clinical care of the mom. There are clinical challenges, however, and this is where we're getting into behavioral activation. There are risk benefits, not only to taking medication. Some medications are contraindicated during pregnancy, and postpartum, women prefer not to take a medication because of breastfeeding. For some, it's a choice they want to pursue and that they can do safely. But more often than not, women are preferring a psychotherapeutic approach rather than a medication. And what's unique here is that there are also some treatment-related needs that young parents need when they are in the phase of pregnancy and postpartum. One, they need credible information about fetal or infant development and parenting and how to function as a family. There's new introduction of stress pileups with an infant's unexpected reactivity, let's say crying throughout a day or a night. there's low access to what we call positive reinforcement, which is there's not a lot of seeking or predicting of rewarding experience in the first 3 months, not until the baby's smiling at you, actually. You often feel that this is a fully robust, rewarding experience. And there's a lot of exposure to aversive context, ranging from the small micro moments of a diaper to a more tedious routine that tends to play out over time. There are barriers to what were previously experienced rewarding contexts or self-care routines. A mom who prided on being able to do a regular exercise may no longer have access to that. And then again, the variability of the infant schedule demanded by biology and development alters the mom's ability to have a regular routine or circadian rhythm based on the care. Now, again, I want to just note that postpartum can affect men, but in this case, we're really just focusing on the mom. That's why I'm using that language. Nonetheless, parents may feel the limited exposure to their pleasure and enjoyment from the routine or what they previously found rewarding. They have to approach an infant who is showing aversive experience and to alleviate that. So this is what we call a high rate of escape conditioning. I'm moving towards something to turn it off to hopefully induce a calmer state among the infant. There's exposure to punishing or aversive contingencies, for example, arguing with a spouse about or a partner about how to best care for an infant. And then ineffective or a lack of immediate change that often occurs. A mom might come in saying, I've tried a variety of ways of trying to help this baby to settle down. There's a lot of fussiness at certain times of the day or the night. And the effort put out to parents or care for an infant does have a cost. It requires energy, focus, and potentially not always an immediate feedback that's useful. So if we look at behavioral approaches or modeling of depression or even bipolar here, this would be, I think, a great snapshot to encapsulate what behavioral activation is about. We know we have the low reward and positive reinforcement I just talked to you about, the higher rate of trying to get out of stressors, exposure to aversive contingencies, responses with a cost, fatigue, energy, and otherwise, and then sudden changes that are occurring when a baby arrives home. You have then the challenges to the mastery level. This is a new mom. This is a whole new paradigm shift for them in terms of caring for an infant. Increased stress exposure, lost resources, and reinforcement, which produces this affective, cognitive, biologic alteration, disruption that you're seeing. And that, to me, is really where the PHQ-9 sits. So the symptom set that you're looking at is reflected in that box, that yellow font box. A best way to cope is to probably directly address these sources or these challenges, but it's not often possible. And so being able to settle an infant might mean that a person has to be overly active with the baby or potentially withdraw to just cope at home with the baby, not take the baby out. It could be avoidance of discussing change with partner and inactivity because of the fatigue that's occurring. So what you're seeing here is this activated state of this particularly unique scenario in pregnancy postpartum, and women really responding with a variety of coping strategies here in the red that are predominantly creating a stress pileup. They're not considered the most direct or effective method of managing. So the key thing I want to point out here is there's really a functional interaction between the infant and the caretaker, and understanding the discriminative stimuli, the specifics that occur in the context of the caretaker and the infant, and what the caretaker is doing to functionally change the infant's behavior is really a key part of understanding what function is. And when we talk about function of behavior, the purpose of the behavior, we're really talking about the discriminative stimuli in the environment, the interaction between the caretaker and the infant, and then what the caretaker's behavior was designed to accomplish, and whether or not that invoked a sense of relief, which would be positive reinforcement, or holding off, which would be holding off or extinguishing a negative reaction, which would be negative reinforcement. The treatment, therefore, is directed really what we think of as an outside-in approach to decrease avoidance and increase the approach of moving towards or anticipating rewarding stimuli. So very minimally is there conversation with your patient about how they think about things and trying to modify sets of thoughts or to emotionally regulate them or to have them do mindfulness. We're really focusing on behavior and the interaction of the behavior, the function of that behavior with the environment to facilitate an improved mood state and reduce those symptoms. So you can now guess, of course, that the mechanisms of change theoretically are increasing the positive reinforcement of healthy behaviors to reduce or buffer their exposure to those aversive contexts if possible, helping them build rewarding contexts or self-care routines that permit that person to at least have some semblance of relief of this hard work they're doing, having some consistency in their schedules that align with the night and daytime activities. Again, a difficult clinical challenge when you have a mom who's doing breastfeeding at night. To extinguish some of those subtle avoidance patterns or the outright escape conditioning that you may be identifying with your patient. And then setting up some trial behaviors in a small way, but fading out your oversight of those behaviors once the patient is showing you competency in their ability to do them without your monitoring them. You certainly want to shape competency or mastery of specific skill sets if possible, and helping that person achieve progressively harder tasks or more complex tasks. So that might be simply just if a patient is organizing that they have a certain goal to get up in the morning and to eat breakfast before they care for the baby, or to eat breakfast at some point during the morning, then you're setting that up, but maybe you start with a small part of that sequence of behaviors in order to help that mom build out the competencies for that. Now, broadly, there's a tremendous amount of efficacy data on BA behavioral activation, and I would recommend you take a look at the meta-analytic reviews. There are several of them. The key work came from Seattle, which was from Neil Jacobson and Sona Demidge and myself. And then there was some complementary work that was done by Carl Lejwe, who's really extended that work into Axis 1 and 2 patients. We have also taken a look and built a behavioral activation inpatient program where all of our staff, nurses, doctors, social workers, and so forth, all speak behavioral activation and teach this on the inpatient space for acute care psychiatry here at Northwestern. I'll bring to your attention, however, there are two excellent studies. One was an internet-based behavioral activation versus treatment as usual study comparing BA guided internet and then using just a treatment as usual. I think there was just allowing to have education. And there were large effects showing a significant difference between the two. Approximately 60% of those with the BA showed some clinical change of post-treatment, compared with about 30%, which was expected in the treatment as usual group. The challenge here is, of course, retention for individuals using an internet BA approach. A follow-up and more recent study, which I think was well done, was a pragmatic randomized clinical trial with pregnant women who were showing depression, and they did a 4-site program over on the northwest side of the US. They had a 10-session phone-based BA compared with treatment as usual, and again found significant reliable differences between the BA group and the Tau group. What's of interest here, and we're talking about mechanisms, is that BA participant showed a significant change in more activation and more environmental rewards. So there clearly are changes in specific directives that the patient is pursuing. And we've also found this as well in our own work here at Northwestern. Let's talk broadly. I'm going to give you kind of a helicopter view. This is a 10,000-foot snapshot of the structure of treatment. And then at the end of this talk, I'm going to talk about how we've integrated in, you could integrate it into the OBGYN clinic, coordinating with perinatal and postpartum visits. But essentially, in its original form, it was 16 visits. It could be done over a weekly time frame, once a week, and that was on an outpatient basis. It's since then been reduced and tested, as you've seen with the Demidge program, with 10 sessions. And in our own work, we've also found we can reduce it to 10 sessions as well. That means, however, you have to move pretty nimbly through each of these sessions. But the work and the structure of each of these sessions is very simple and intuitive. So the skill that you're wanting to work on in terms of your own delivery of this is to be able to have the materials in front of you so you have a visual aid as you're starting to explain some of these particular techniques, and that you're having individuals or patients put down some of their data while you're describing it to them so that they can engage directly with the practice of these particular techniques before they leave the session. We have been able to set it up so that the techniques that I've listed here can be really reduced into components. So if, let's say, you have someone who is not doing very well, is emotionally activated, in session 1, you might just simply work on activity monitoring and delay to have them look for goals of enjoyment and mastery, or GEMS, that's what we call them, and have them do that in session 2. So you're certainly welcome to pull these apart into a longer program, depending on what your patient needs, and then threading them through, because each technique is essentially a setup for the next technique. So I like the fact that there's a way in which you can pull this apart, or you can condense it if you have someone who's moving pretty quickly through the material. Let me talk briefly about each of these sessions. And again, feel free to reach out with questions if you have them. The principles are really the first session you're wanting to map out. There are 10 of them that are listed in the Martel Demijan book, but we've picked 5 because we thought that's what people could retain. And the first thing we wanted to really highlight for them is that they want to be following goal-directed activity, not the reflexive mood or habits that they tend to be experiencing. So trying to have an override of their instrumental goal seeking over the reflexive mood is really the skill set that BA is trying to promote. We know that behavior has a function, and so it's helping them understand what function means, that there's a behavioral meaning depending on the context. If I go get a cup of coffee, it's my first cup of coffee in the morning, that may have greater meaning to me versus my 6th and by 11 o'clock in the morning. Natural rewards will change behavior, so seeking a sense of competency and pleasure, not using monetary or food as a reward, these are considered secondary rewards. There's a way in which we could help individuals actually anchor a goal and then reward themselves to produce the likelihood of them seeking that goal again. And then this is finally a collaborative model, so we work together, both the patient and the clinician, discuss each of these techniques. You're instructing them, but you're also having them engage with you, and generally having them walk you through it after they've shown initial competency. The first set here for session 1 is also linking the mood to the activity. And so what you have them do is some daily activity monitoring, which identifies a variety of things. Depression, on a rating scale from 0 to 10. Avoidance, if you think that's useful to know. Some disruptive routine, stress pileups. Part of this is invoking change to help them become more aware of what's going on. But you're also you are, I think, able to really capture what's going on in the course of the day or the night with your mom. So you're asking them to rate how enjoyable they find a particular activity through each hour of the day. And they rate that between 0, which is none, and 10 to very pleasurable. That's a rarer occurrence, of course. And then mastery, which means how well did you do it? And could they rate that between 0 and 10? To make this less abstract, here's an example of this. So we had someone record what they were doing in each time slot. They rate their depression and so forth. And so we see here at the time on the left-hand column, 2 to 3 a.m., the person was up twice, and the mood was pretty down or blue. There was no enjoyment and very little competency expressed there. They slept and then back up again at 5 a.m., same mood state, and no mastery, no enjoyment. So the challenge here is to ask a mom to fill this information out when they're already quite busy. So you could ask them just to fill out mornings if you think those are particularly difficult for the mom, or you could have them just do a couple of days. Any data is better than none, and that data really allows you to have a robust conversation about the kinds of things that they're doing and how, frankly, best they are serving themselves and the infant based on the choices that they make. So we had discussed with this mom about how to change their nighttime routine and to get some support from the partner. You'll note they were up with the baby twice and didn't ask the partner to help. Therefore, finding themselves pretty fatigued. So session 2 is scheduling the GEMS, goals of enjoyment and mastery, and having them focus on the activities that increase those things that directly hit against those symptoms. They either alter or substitute activities that make them feel depressed. And so taking that data that you've had from session 1, you ask them what to schedule to increase the mastery that they're going to have, and ways in which they think that would actually seek their goals. Part of this has a conversation about values, and we can talk about that. A person may value themselves to be a good parent, or to take care of their home well, or to be a career person. The aim is to have these goals personalized to the patient, and then you begin with those. In this case, we had a mom who's planned a GEM at that same time point where there was a lot of stress and sadness. And so I have the prior ratings there for you. So under mood, prior week was a 7, but in this case, this coming week, it was sleeping. So the person was able to sleep as the partner covered the feed. And then they were up at 7. And you notice the change between last week, which was 7, and this week, which was 3. Pleasure is from 0 to 5, and mastery is also increased as well. So I'm not implying this is a simple act you just do with each of your patients, but with a little fine tuning, with some careful listening about what your patient is really valuing in terms of a goal of enjoyment and mastery that directly hits on that depression, I think you'll find that you may be able to change some of the specific hours by hours. And once you've done that, you're again showing this person how they can do this for themselves. You no longer need to monitor it. The question is, what kind of activities could they use to increase goals, to increase enjoyment and mastery? And often, as we've talked about, it's the values, the value set of, let's say, being a better parent, or to be a better partner, and so forth. And so what you can do is have that conversation and ensure that the behavior set that you're seeing on the daily monitoring record is really reflecting that. You can also take a look at barriers to living the values that the person's talking about. Okay. I just want to actually, if I could, talk briefly about the 10 things that you could do when you have a activity sheet. I just want to briefly just talk about that. So I'm going to come back to this, because I think this is a great way for you to brainstorm when you're getting this data, a whole mass of data, and how you can make best sense of this to conceptualize it. So here are the 10 things I think you could do with this measure. You could view the baseline activity level. You could take a look at the range of feelings that you see. Depression, it could be also a measurement of suicide or anxiety, depends on what you pick. You can take a look at the breadth or the constraints of activities. It might be that there's a very narrow routine we see here. You might see someone also pushing themselves in all domains, and it's just tiring or creating that extreme fatigue they report. You could take a look at the avoidance patterns the person is presenting. You could see whether there's any progress towards short-term goals that they've set out for themselves. If there was no enactment of those goals, you might want to take a look at the obstacles that got in the way. You could take a look at timing. When do they feel depressed? You could look at activities that they're over or under represented there. I guess that would relate to kind of a broad or narrow routine. Activities that with a higher mastery or pleasure rating, that would be good to take a look at and see if you could bootstrap some of those, either repeating them through the day or once a day, or adding some component that would make it feel a little bit more pleasurable. You could also work on scheduling goals with circadian rhythm if you needed to. So if you have a mom who's staying up till 3 in the morning, you obviously know she needs to sleep and not clean up her kitchen. So there may be a value in having her try to get back to sleep. There are also areas where you could look for sources of reinforcement. Where is the pleasure in their environment? Is it at the Starbucks? Is it a friend who calls? And where are they located, and how accessible are those? And trying to figure out a method by which you could create a routine in the environment that allows the greater access. Okay, so there's a brainstorm on the daily monitoring and the scheduling the GEMS. We've talked about values, and now we're moving into function. This is a critical part of the behavioral activation. The focus here is to assess those circumstances, those environmental contexts that elicit the depressive symptoms and the function of the response. So if you have a mom who hides sleeps in bed, doesn't get out of bed with the baby most of the day, the question is what's the function of that behavior, and what was the circumstance that elicited them to feel this way? And so you might take a look at the ways in which a mom will explain the avoidance. So they may say things like, you know, I avoided it because I just didn't see that it was going to be a bad day, or I can tolerate these things, or it just distracted me and helped me not think, or I didn't know that it was going to be a stressful scenario, so how could I stop? So part of what we're doing here is to understand both the trigger and then the function of it and then the consequences. And here we have it mapped out very simply. This was a amalgam of a patient who reported, the partner told me that he had to work on Saturday, leaving me with the kids. One of them is an infant newborn. I stayed in bed and he had to give them breakfast. Okay, so we clearly know the trigger is what the partner had to tell the mom. The mom's now burdened with a full day, unsupported with the children. And the mom decided she's going to stay in bed, and the partner now has to do the child care. What is it that she's communicating? What's the function? Well, it could be that she's saying, I'm overburdened, I can't do this. It could be that she's trying to get as much sleep as she can. It might be a functional thing in the sense that it's adaptive. And until the partner leaves, she's then taking on childcare then. But it turns out in this case, it was really just a passive way of expressing to the partner that she was dissatisfied with this arrangement, didn't feel enabled and assertive to say something to that partner. And so what happened was there was an increased argument with the partner. The kids were disappointed not to spend time with mom. And on the other hand, there was more sleep, and there were positive consequences with sleep and reducing her stress. So what we wanted to do was to have this person really identify why they are avoiding, because we know avoidance generally will create problems in quality of life. It is related to inefficient sleep, immunity challenge, stress pileups, and so forth. The mechanisms, and we took a look at the literature, most of this generated in the 1970s actually, where explanations for avoidance are varied, but here are some potential explanations. We have a deficit in the ability to perceive threatening stimuli, or just not attending to what is threatening. Well, that doesn't seem to pay much heedance to what we just talked about in terms of this mom kind of trying to withdraw and communicate she was dissatisfied with the plan. We have an inadequate search of environmental cues that triggered the depression. Maybe she was aware of what the partner said, maybe created it, maybe not. There was avoidance of anxiety-arousing stimuli and the consequence. Well, that sort of seems like that would fit. This person didn't want to have a conversation, a direct conversation with the partner. They could not go out for the day and leave them fully saddled with the children when they were already feeling pretty depressed. There may have been inaccurate or incomplete information about what to expect of the environment, or there could have been ignoring of warning signals in conjunction with higher tolerance of pain. Maybe she's saying to herself, you know, this is bothersome that this person has done this, but I'm going to handle it because I can take it. So we focus on moving that information into identifying what we call traps. And this is an acronym for trigger response avoidance pattern. You have a distressing situation, in this case, a partner saying, you're taking care of the kids for the day. The response might have been depression or sadness or anger, or it might have affected behavior. In this case, this person went to bed. The avoidance pattern is staying in bed, not talking to the partner about changing up the routine of that day. The problem is the avoidance pattern turns back into supporting the response. There's no change of the trigger, which was the elicitor. And in this case, we now want to help this person work on tracking, which is the trigger and the response still remain the same. In this case, this is a scenario of a partner staying out late, a mom being really angry and sending texts that she was upset. And then once the partner came home, talking directly with the partner about change of behavior, not staying out so late because that was disruptive to coming home in the night routine, and altering or directly managing everything in the red box and the trigger. So the AC, the alternative coping, is really altering the meaning or the timing, the availability of resources if possible, using shaping or fading or extinction to change the context, to change the elicitor. In this case, that's what happened. The partner stayed out late again. She was response. Rather than sending a text, what she did is she talked to him. She got some social support. She felt better in control, and the partner promised to change behavior. We now move to session 7. We're identifying some sequence of behaviors to reach a goal. This is an observance in the fact that a lot of women have a lot to do, and you can't really do all of these steps at the same time, but you can certainly try to plan some tasks and move towards climbing the rungs of a ladder safely to get at it, to try to change that the goal. In this case, you would assign some stress units of, these are called subjective units of distress scale, but essentially it's really asking a patient to tell you between 0 and 10 how stressful they felt each of these steps were. You might use a graded task approach where you say, okay, we're going to try to have you do a couple of these tasks during the week. Let's schedule those. Let's make sure you're doing some rewarding activity afterwards. And you use that graded task to put together increasingly difficult goals or to have them habituate to the anxious effect that they may be experiencing. You can role play this if you wish to. You can have them disentangle what feels difficult to what actually can be accomplished. Sometimes just getting out of the car and putting in gas in the car feels like a real burden, but it turns out it lasts around 3.5 minutes. I've timed this, and the outcome is a big payoff. So there's a way in which you can break down small little tasks for people, for women through this phase that will help them get to the goal of childcare, self-care, and feeling better. Finally, we're getting to the last 3 sessions of 8, 9, and 10. These are focused on building goal-directed behavioral repertoires. What we mean here is replacing reflexive mood-dependent behavior with goals that really challenge the symptoms. And that's helping the person become more contextually aware, using behavioral experiments, anticipating and correctly predicting where reward will be in the context of the environment, to increase their approach behavior. And if you have natural rewards that are available regularly, that will set up a nice routine that will battle the depression back. It also may certainly set up some markers for setting a circadian rhythm for women with bipolar. So the techniques might include organizing some social support for parents and family to help. If that's not possible, it might be friends, it might be groups of women who get together. Certainly in the perinatal world, we often find patients reporting that they got a lot of their support through Facebook, Instagram, with other groups of mothers who are going through similar challenging scenarios. We also help them understand that behavior is data. So the data, collecting the data and letting that speak to the patient and yourself allows you to collect relevant information about what might be actually eliciting the depression and what might also challenge it. And then acting as if to counter the depressed moods. So this is where really trying to challenge that reflexive depressive state to behave differently with the idea that presumably mood will change once someone has become accustomed to acting differently. We do target rumination. We don't discuss what's really the content of the rumination, but we see it as a cognitive distraction and a behavioral withdrawal. And so we often talk about the function of the rumination. What is the signal telling you that someone is ruminating? They're thinking about depressive experiences in the past that make them feel more depressed or anxious, or they're anticipating things that are going to occur based on ruminative experience. We think of this as escape or avoidance or ineffective problem solving, and trying to help them contextualize or to anchor themselves into the moment. I guess you could say this is a little bit like mindfulness, is being aware of the context and trying to challenge the context, not the content of the rumination. So for example, it occurs a lot while driving, it occurs a lot while sitting idle. And so having a person schedule those activities that directly challenge examples where they're ruminating might be a good idea. Finally, to make some sense of all that has been covered, there's a discussion about sustaining gains. And so there's treatment planning for maintaining those gains if possible, pulling out the specific techniques and strategies that that person benefited from and putting together that set for them, prescribing for them to go ahead and rehearse these, for example, for over the next sets of weeks. So you might have them use the goals of enjoyment and mastery sheet in session 2 to schedule out a session for themselves to review the work they've done thus far. It might be to write a letter to themselves so that they are able to remind themselves of the things that were workable that really helped them. It's to help them also to review their progress. You're using measures, certainly in the beginning, the middle, and the end, if possible, to assess that symptoms have reduced, but also what were the mechanisms of change that help them. And I'll talk about that in brief in a minute. We would want to make sure that they're focused a little bit on identifying the skills that did not help and the skills that did. List out those coping skills and have them obviously regularly practice them, we've talked about, and then track and reduce avoidance. I will say at this time, we do highlight a lot of healthy behavior work. So we talk about, maintaining healthy nutrition, trying to maintain a healthy lifestyle if possible, and to build in a little bit of exercise if they've been cleared by their doc, their OB, to do so, because that is a great way of reducing stress and maintaining cognitive clarity. There are ways of measuring the theoretical mechanisms of change in behavioral activation, and they're really focused in 2 areas. These are all self-reports. The pleasant event schedule is a long, lengthy, slightly complicated self-report that looks at a list of specific pleasant events. It was built in the 1980s, and so some of them are referent to activities that were popular then, like getting into a hot tub. You would ask a person to fill this out, but it's really something you would want to have them take home and spend time on. If you wanted to shorten it, you could get the short version and have them take it home, and to identify pleasant activities that they think they would like to schedule for GEMS. We often find women in the perinatal phase very busy or focusing on other things in preparation for a delivery or in postpartum and actively caring for children or infants. And so it's difficult for them to identify when they would actually be able to do some of these things, even if they could identify some pleasant events. And so part of that, your challenge as a clinician is to feather those into the course of a day, whether it's just a 3-minute, a 5-minute, or a thought about anticipating that it's going to occur at some point in the future might be something you could try. So we use the pleasant event schedule both to generate ideas, to track pleasant events that are currently occurring, to identify obstacles that may be interfering with them, to also see if there's ways they could feather those into a routine. The behavioral activation depression scale was developed by the Cantor team, and the references down below. Essentially, this is a great self-report that takes a look at the experience of the positive reinforcement that occurs in the environment while someone's doing behavioral activation. And a change on these scales suggests that, on this particular subscales, show that there's an alignment with symptom improvement. The next 2, environmental reward observation scales, a 10-item, very short self-report, and then the reward probability index was an updated version of that. It was really a method of trying to take a look at the ability, or I would say the probability of reward in the environment, and then the what you call dimensions that would suppress their access to reward in the environment. And that's why it's called environmental suppressors. So there's 2 subscales on the reward probability index that I think are quite useful. And again, change on those for the better, meaning increase reward probability and decrease environmental suppression, suggests that there's a change in symptom improvement. So those, if you're looking to really to measure mechanisms of change in the context of the treatment that you're providing with BA, feel free to use them. They're very simple, intuitive, and you can track change over time. So we talked about the structure of treatment. This should look familiar. We've done the activity monitoring, the scheduling, and the aligning with the values. And if anything, it's almost like you could think of this in 3 parts. So session 1, 2, and 3 could be threaded together very nicely, right? Monitoring, scheduling, and they should align with values. The next 3, 4, 5, and 6 are find the function of the avoidance, get the trap, and then change that avoidance into a coping strategy, a track, right? So 4, 5, and 6 could be linked or sewn together. And now we're building competencies in 7, 8, 9, which is building those ladders, rungs that are set at a safe distance so someone can climb them, goal-directed behavior to override the reflexive mood state behavior, and then rumination is signaling action or context change. You can sew those together. So you really could package this if you wanted to into 3 parts, and then session 10 is a summary session just to ascertain gains, as I've discussed. Now, if you're wanting to organize this into an OBGYN visit to have the convenience for the patient, either because they would like to visit you while you're on the OBGYN department in that space, or they can come across to your clinic after they've met or before they've met their OBGYN for prenatal care, postpartum care, you could take a look at putting them together once a month. So for week 4, 8, 12, and 16. And then go ahead and have them meet with you every other week as they're coming in, starting towards the latter part of their trimester care. So we've found that this could be a way in which you could have a person engage with BA, again, a little more diffuse because it's not so regular, it's once a month up till the end, but it is a method by which you could conveniently wrap the BA around the prenatal care. Now, postpartum, we often have women coming in being identified as postpartum depressed. There's a fresh onset of depression or bipolar, and we will have them meet with our psychiatrist or our licensed clinical social worker as regularly as they can come in. So that doesn't preclude you from only having one session postpartum. You certainly would want to have regular meetings weekly if possible, and that's the model that we use, generally up to around 4 to 10 sessions, depending on what the mom can do. Finally, I'll just mention that you can extend beyond the clinic. You can do this over the phone. We ourselves have done a behavioral activation for bipolar depression trial. It's a small pilot trial where we were able to do outreach adequately using phone. And the advantage to that is that women find a lot of obstacles to come in pregnancy and postpartum because of they're managing multiple domains. And so being able to access someone regularly by phone is a convenience both for the clinician as well as for the patient. So let's take a look here. We had Sasha who showed a PHQ-9. It needed some attention. So week 8, she was able to come in and we introduced the BA model and the manual. She took the manual home with her. She was able to monitor activities and set some gems. She came back 8 weeks later. We talked about avoidance and tried to maintain that momentum through week 24. And then when she was able to come back for the last 3 visits, we had her climb ladders, pursue goals, and then signal and catch her rumination. So you can really pull these apart if you needed to. So let me just finish up here and then I'm going to take some questions. I just want to talk about methods of advancing care. We've talked about ways you could use an OB psychiatry collaborative care model. We've done that very successfully, and we've been highly surprised by the number of women who welcome the opportunity to talk with both their OB about the mood symptoms they have. Giving the OB a self-report measure has really allowed them to be able to correctly identify when it's a pregnancy symptom, postpartum symptom, but also when to refer over to psychiatry, either in the collaborative care program or into psychiatry outpatient care or inpatient if necessary or hospitalized. So it's been an excellent way in which we've been able to increase communication and increase our identifying cases or patients who are suffering. Secondly, we've been able to also test some mechanisms of treatment response, and we've thought about using experience sampling methods. We've thought about depression really just being affective disruption that's related to hormonal mechanisms and change of identity and stress. And so we would welcome the pursuit of research that would take a look at an RDoC framework of negative affect, positive affect, reward systems being altered during the course of the perinatal phase. And finally, as always, it's useful to think about things in multi-level with neurobiology and hormonal mechanisms, which I haven't talked about today, but really are at play here. And seeing the processing changes and challenges that women go through as they are going through a normative pregnancy. We also know that this is, again, a conversation we've had in the last hour about normative presentation. We have not discussed scenarios where we see women who are suffering from grief, from preterm loss, from comorbid medical issues, for taking medications that they're concerned about. And so in the perinatal field, there's a value in really beginning to start to take a look at the dashboard of factors that contribute to the presence of mood disorders, but then also beginning to create what is more precise in terms of a treatment for each woman who comes in reporting mood disorders. Okay, so I'll stop there. You guys are welcome to reach out to me if you'd like manuals or discussion about how to get training, how to assess competency and adherence. There are very good scales that allow you to measure your own ability to deliver behavioral activation according to what's prescribed, what's expected. And certainly if you'd like more details, feel free to read in terms of looking for reading that we have here is just a very short list, so there's way more than this out there. Supportive and credible sources of information about perinatal mental health. So thank you very much for your time.
Thank you so much, Dr. Golan, for your excellent presentation. We're now going to start answering the questions that were submitted during the presentation. You were talking about doing BA over the phone. Here is another practical question. Do you invite moms to bring their babies to the session?
We do. In fact, it happens a lot. It might be multiple children as well. So we have a space that has toys to allow children who are capable to play while we do behavioral activation psychotherapy. We also have a space where women can bring in their own strollers. We have bathrooms that are specifically designed to allow women to change. We have diaper genies and so forth. So we've really thought carefully about accommodations for women to bring in their babies. I like seeing it, frankly, because it allows me to engage with the mom as she's engaging with the baby. We have many babies who fall apart in our sessions, and it's nice to see how the mom is coping with that stressor. Not because it's nice, but it's an opportunity for me to really observe how well she's coping. How can she use her own parenting skills? Can she boost them up? Does she need a parenting therapist to help, or doing some reading? Normalizing it as well. I'll tell you the similarity across cultures among moms who soothe their babies, and that's such an interesting thing to see.
Thank you very much, Dr. Golan. We have a question here that has to do with goals and treatment. How would you suggest setting goals to start scheduling enjoyable activities?
It certainly depends on the mom. I think we begin with a conversation of what she likes to do, or what she thinks would reduce the depression or the affective state she's in. We might, if she's out of ideas, I think I would begin with routine regulation. And again, a challenge and a sensitivity here about a mom who's decided she's going to do breastfeeding at night. So how does she get her sleep later in the day? How is she setting her own priorities for infant care, her care, and so forth? So it might, as I will transition to get back to work. So it might be a goal that's coming up that we work towards. It might be personal health goal, an extracurricular goal. So again, having it patient defined. If the patient's out of ideas, I take a look at the daily monitoring sheet to see if I can take a look at how that presents. And as I talked about those 10 things that I look for, I begin to have conversation with the patient about whether they're over and under engaged and whether things could be changed in terms of avoidance.
Thank you very much. Here's another question. I noticed the structure of treatment seems to follow low-risk pregnancy per OBGYN visit schedule. How does the structure of treatment change with a high-risk or preterm pregnancy? Are those mothers considered high risk for PMD?
Yeah, this is a fabulous question. This happens to be most of the women we see, actually. In our collaborative care psychiatry, the OB psychiatry program, we have high severity cases with low income, low resource access. We spend a lot of time educating these women and getting them to see a psychiatrist and a psychologist in psychiatry if they'll come, or doing the collaborative care programming. We would work on activity monitoring. We would deliver enroll this BA approach, as I've discussed, because it can work very well with cases of patients who are intensely distressed. The caveat, of course, is if they're suicidal or going to harm the baby, then we would administer the recommended treatment that I talked about earlier in terms of hospitalization and medication and safety checks. So I'm hoping I'm answering your question, but we would use BA. You can have confidence that it's useful for patients who are showing severe levels of depression and anxiety, often we're spending a lot of time with outreach to ensure that they're coming in for that care.
Thank you, Dr. Golan. You were just talking about harm. Here's a question that ties into that. What are your thoughts about how best to distinguish the obsessive thoughts about the possibility that one may deliberately or inadvertently cause harm to an infant in a mom who has a new onset OCD or panic disorder from genuine homicidal ideation that is postpartum psychosis?
Perfect question. I love that question. We do see that a lot. It is worth your actively listening to the patient's responses about their ability to control their thoughts. So I'm looking at obviously what they are thinking about. I'm looking for insight to see whether they recognize them as distorted. I'm looking at impulse control. I'm ruling out other behavioral variables like alcohol use in an environment that's highly stressful that could trigger like domestic violence or other scenarios where a mom may have access to means. I believe the differential between the two is really that the mom is scared by these obsessive thoughts. So classic postpartum OCD or depression, the thoughts are so disorienting and scary that you see obvious distress about it. But we still do a lot of safety planning. So we will remove the baseball bat from the trunk of the car and have it given away. We will ensure that we increase our monitoring and treatment options with that mom. We certainly would want them to be seeking a conversation with a psychiatrist to think about medication. So I'm hoping I'm answering your question. I think it's the presence of distress that the mom is showing about these being strange and senseless, disorienting. It's again about her ability, capacity, availability of means, history, of course, the current stress she's under and the methods by which we would try to reduce that stress and then boost up biologic support through medication.
Thank you very much, Dr. Golan. You still have two questions. In the beginning of your talk, you were talking about bipolar disorder. Here's the question. In your experience, is the depression phase of bipolar disorder more difficult to treat with BA? So
let me make sure I'm understanding the question.
Yes. So in your experience,
the presence of bipolar in a hypomanic or manic state harder to treat if you're using behavioral activation. Is that correct?
Right. Is the depressive phase of bipolar disorder more difficult to treat with behavioral activation?
Interesting question. Not in our experience. You take a look at the bipolar disorder collaborative care program, which was run, it's a manualized program at Mass General. It was designed to re-regulate circadian rhythm, to have the individual challenge their thoughts, CBT, using stress reduction and increasing communication with their early phases is quite useful for regulating women who are showing either subtle signs of bipolar or outright hypomania and mania. So I don't think so. I think it's actually a pretty good fit. We have found it most useful for the depressive phase of bipolarity, and that's what we've tested it for. So I think that in of itself is also quite useful too.
Thank you very much. Here's our last question, basically about resources on BA. Could you please recommend treatment books, websites, and apps for patients that emphasize behavioral activation? With this comes the question, how does one get training for using BA? And then there are a number of, yes, and what was the BA manual that Sasha was using? Could you share those with us?
Oh yeah, I can certainly share. There is so much. I have a full collection of it. I troll around, you know, in the international arena to look for BA related articles and PDFs and so forth. So if you want to reach out to me directly, I would be happy to send you a zip file of things. Training can be obtained both by reading the Martel Demidzian book, to take a look at the manual, and then also it's the Michael Addis workbook, which is a pretty good, it's a text-heavy workbook. Our patients tend to get bogged down in the text of it. So we've revamped it, and we have manuals that are very clean looking that I'd be happy to send to you. That we have both clinician versions and patient versions, and they're available for dissemination wherever if you'd like to give it to your trainees as well, you're welcome to. And if you're looking for on-site or by phone or Skype training, I'm happy to do that in terms of helping you, your team, install the program or just to get some general competency and feedback. I offer supervisory feedback on 2 randomized clinical trials, and it's a lot of fun getting to know and hearing people's clinical styles and then giving them direct feedback about how they can align their work to present a more robust BA approach. So the short answer is give me a call or send me an email. You can find me on the internet, and I'd be happy to help you.
Thank you so much, Dr. Golan, and thank you very much to all our participants for attending today's webinar and for your excellent questions. You will receive a follow-up email within 48 hours that includes a link to the evaluation and a link to the recording of the webinar. And please do share your thoughts with us. If you're not yet an ADA member, please consider becoming one. ADA offers an excellent members benefits package such as year-long access to continuing education, free access to special interest groups, including peer online consultation groups, significant discount to ADA's annual 4-day conference, promotion of your practice in ADA's online Find a Therapist database, and much more. We hope you'll join us at the Anxiety and Depression Conference coming up April 5 to 8 in Washington, D.C. And on behalf of ADA and our presenters, thank you for joining us today and have a great rest of your day.